Alright, so this is going to be going over abnormal delivery and complications. So the first delivery stuff we talked about, it's not truly an emergency. Normal delivery is just normal delivery. We're there to assist. In this case, your abnormal deliveries, these absolutely can become an emergency. So this is where really gets a little bit hairy sometimes. So first we're going to talk about breech presentations. And technically a breech is anything other than the crown presenting. And there's different types of breech presentations, but it's a different part of the body besides the head's coming through first in the birth canal. So you have a frank breech presentation. This is where the hips are flexed and the knees are extended, and the buttocks are the part that's presenting, much like the picture that you see there. You have an incomplete breech presentation. This is where one or both hips and knees are extended, and you may have one or both feet that come out first. And you can have a complete, where the hips and knees are flexed and the buttocks are the presenting part. The only type of breech that you can deliver in the field, and it's not ideal, but the only ones that you can do is a incomplete where both feet are presenting. Okay? If the buttocks are presenting and delivery is imminent and you're not stopping it, okay, position the woman with the buttocks at the edge of the bed of the stretcher with her legs flexed. Allow the buttocks and the trunk to deliver spontaneously. Do not pull on the newborn. Once the legs are clear, make sure that you support that body. Alright, you're going to have to keep the newborn a little bit lower so it's kind of in a slightly downward position, but still supporting that newborn's weight, because if you let the weight pull on the head, that head's still internal, you could cause internal distraction or other kind of complications that we don't want. Once you can see the hairline, alright, grasp the ankles and lift upward slightly. And if that head does not deliver within 3 minutes, that newborn can suffocate. We're not going to forcefully pull it out, but we may have to assist them. So you may have to take a gloved hand, put it in the vagina with the palm towards the face of the newborn and form a V with those fingers placed on each side of its nose, and push that vaginal wall up and away from the face until the head delivers. Alright, but don't just try to pull that newborn out, because it can cause a lot of damage there. Okay, it can cause cervical injuries on the newborn, so we don't want to do any of that. Maintain that airway throughout transport, and if that head does not self-deliver, alright, rapid transport with the buttocks elevated on the pillows, maintaining the level position of the newborn's body, supporting the body the entire way, and early notification of the hospital so that they can prepare. Alright, other breech presentations are pretty rare. That one truly is going to be your most common presentation, but you could get a footling breech or a transverse. A footling breech is where one or more feet will show through the vaginal openings. A transverse presentation is where the fetus lies crosswise in the uterus and like one hand may show in the vagina. We don't mess with that. We can't. There's nothing we can do with that. So in these abnormal presentations, we're not going to even attempt delivery in the field. It's not happening. We're going to provide rapid, safe transport to an appropriate facility, hopefully with a NICU and OB, labor and delivery. Okay, if that's not feasible, a hospital with an ER, but ideally, it's going to be much better to go to one that has L&D. Alright, the next problem, prolapsed cord. Alright, so this is where the cord actually emerges before the fetus, and it gets compressed between the bony pelvis and the presenting part of the fetus, which shuts off that oxygenated blood supply from the placenta. Problem with that is it leads to fetal asphyxia. Okay, if circulation is not reestablished, then the baby can die. So what we're going to do is we're going to keep the mama supine with the hips elevated. Okay, we're going to give her 100% oxygen, non-rebreather. We're going to have her pant with each contraction to keep her from bearing down. We don't want her to bear down, because when she bears down, it's going to put more pressure on that cord, which then is going to further cut off oxygen supplies. Okay, so have her pant. Then we are going to gently take our hands, and we're going to very easily keep the presenting part kind of back into the vagina until it's no longer pressing on the cord. Okay, and then we're going to maintain this pressure until another paramedic covers the exposed cord with the dressing. So we're just kind of trying to take your gloved fingers and just trying to kind of push the vagina off of the cord essentially, and then maintain that position throughout rapid transport. Safe, but rapid transport. And when we say presenting part, I should probably clarify. The presenting part is the part of the newborn, not the cord. All right, next one, shoulder dystocia. So with this, this is where the shoulders cannot clear the pelvic ring. It could be because the shoulders are large in the newborn. It could be because the pelvic ring is not opened up enough in the mom. But whatever reason, shoulders can't clear the birth canal. All right, some risk factors for this: diabetic women, a large fetus, or a post-term fetus. So if they've gone, 41, 42 weeks or something like that. Okay. What you see is that the head delivers, the shoulders can't go past the symphysis pubis, and then they get kind of pulled back in the vagina a little bit, almost like a little prairie dog, like whoop, going out a little bit, going back in, going out a little bit, go back in. All right, so major concern for this is brachial nerve damage. We don't want that. And if they can't get through the birth canal, they can't breathe. That's, kind of a problem, right? So what do we do with this? First thing we're going to do is try a McRoberts maneuver. So we're going to hyperflex the legs tightly to the abdomen. Think like a frog, like you're pulling those legs up and outward as close and as high as you can get them. Don't yank, just general steady pressure to push them on up there. And this is going to try to open that pelvic ring as much as possible. All right, then if this doesn't work, that doesn't work in and of itself for the next contraction, if it goes out and comes back in again, the next contraction when she feels the need to push, we're going to take our hand and we're going to palpate right above that pubic symphysis, right above the pelvic area on the mama, and you're going to palpate and try to feel where that shoulder is. Right, and then you're going to apply firm pressure to the lower abdomen and push kind of in and down where that shoulder is while helping guide that head out. Okay, there's a decent chance that you may end up with a clavicle dislocation or fracture, but that is still infinitely better than a dead baby. So occipital posterior position. With this, they are face up. This can cause a delay in the labor time if that head does not externally rotate, okay? So support mom, support newborn, rapid transport. What we'll see like this is where, we've started the whole birthing process, but then we don't progress. So this is what, this is one of the reasons why we say if things have not moved along considerably within 15-20 minutes, let's go ahead and start heading to the hospital, because we could have something like this going on that we can't do anything with. We can't do in manipulation maneuvers where they, in the hospital they can kind of do some external manipulation where they can literally flip the baby and such. We can't do that. All right. Multiple births. A lot of times in twins, you'll have one head up, one head down. All right. So big thing here is always be prepared for more than one resuscitation, which means we're going to need some help, because you can't resuscitate two babies at once. You just can't. So always going to have, you suspect or know multiples, go ahead and get some help just in case, okay? Twins typically are going to be smaller than singles, and delivery typically in and of itself is not that difficult. The biggest thing is going to be they're going to be a little bit small, okay? And they may be a little bit premature. The second newborn is usually born within 45 minutes of the first one, but it could be, minutes. It could be 10, 15 minutes or even less potentially after that first newborn. Okay? And if there's more than two in there, oh goodness, let's get everybody that's working today to come out and join us. We're gonna try to get as close to the hospital as we can, right? But as far as the procedure in and of itself, it's the same as single birth. You're going to clamp, cut the cord as soon as delivery is complete. The second newborn may come before the placenta. It may not. So, you could have two cords in one placenta. Those are identical twins. You could have one cord on the placenta, and that means they're going to be fraternal, and you're going to have another placenta with another cord. Make sure that you record the time for each newborn. They may be a little bit premature. They may just be really small. Identify the first newborn that was delivered as baby A. So as soon as it delivers, and if you know there's another one coming out, go ahead and put some tape or something on this newborn to identify it as the first baby, so we don't get them confused, because they're probably going to look pretty much the same, unless you get lucky and one's a boy and one's a girl. But make sure you record the time of birth with both of them and identify which one is born first. All right, next one, cephalopelvic disproportion. So basically this means that baby's got a big old head, and that head is bigger than the pelvis. All right, so with this, these are the women that died in childbirth 100 years ago. They'd labor and labor and labor, and eventually they didn't happen. So with this, usually a C-section is required, which means, guess what? We're not doing anything in the field. So if they've been told that they have this situation, or, once again, if she's been laboring, nothing's progressing, we know we need to head on towards the hospital, we could have a situation like this occurring, okay? If the head cannot be externally rotated and the delivery cannot be completed, support the mom, support the fetus, rapid safe transport to an appropriate facility, okay? Now, precipitous labor and birth. So with this is where you have a really fast labor and birth time, less than 3 hours. Chances are, this happen more and more the more children they've had. So if they've had, 3, 4, 5, 6 kids, and this could happen more frequently, okay? Contractions are usually more intense. A lot of times this is what's happened if they were delivered prior to our arrival, where it's just like, oh, hey, here we go, and here's the baby kind of deal, okay? Assess the woman post-delivery for tears, bleeding. Usually not so much of a adverse effect for the newborns. They may have a little bit more chance for some facial bruising, or that even a more unusual misshapen head, because babies come out, they got those little like pointy cone heads, and they look really funky. Like, they really do look kind of funky for the first month. Then when they hit about a month, they start looking like cute and baby like. Before then, they look like cone-headed little old men who were usually angry at the world, but that's okay. Right, but they just may have a little bit more funky shaped head. Right, so meconium staining. So meconium staining is the first stool of the fetus that it passes. Typically it's going to be odorless, and it'll be like this kind of greenish black with like a tarry kind of consistency. If it passes while it's still in the amniotic fluid, it can cause a chemical pneumonia in the newborn. Alright, and it could be an indication of stress and fetal distress from the labor and delivery. You won't know if there's any meconium in the amniotic fluid until the water breaks, okay? If it has a yellowish tint to the fluid, then it indicates that it may have been in the amniotic fluid for some time. A greenish blackish color suggests that the recent meconium stain is relatively recent and could be an indication of fetal distress, okay? If the staining is present and the newborn's not responding normally, initiate ventilations, assisted ventilations with non-breathing or ineffectively breathing newborns, okay? If there is no airway obstruction noted, do normal neonatal resuscitation, warming, ventilations, oxygenation, etc. If it is moving vigorously and if it doesn't seem like it really needs assistance with ventilations, if it doesn't seem like it has respiratory stress, then suctioning is not recommended, because that whole cause a more damage thing. Alright, uterine rupture. So uterine rupture can occur during labor. Luckily it's not super common, but it can happen. It is biggest risk for women who have had many children, or those who have scarring on the uterus, especially if they have had a previous C-section, which is one of the reasons we ask about that birthing history, because if they have a previous C-section and they're attempting, or maybe not attempting, but here we are with a possible vaginal birth, they are at a higher risk for uterine rupture. Alright, so signs and symptoms: a woman in active labor who has a sudden onset of feeling weak and dizzy, maybe thirsty, that goes to the whole shock thing. Alright, has had initial strong and painful contractions, but now the contractions have kind of lessened. Alright, they may show signs of shock, but like with all pregnant women, their signs of shock can come in kind of late. Alright, they may or may not have significant vaginal bleeding, just depends on how severe the rupture is. They also may have a very rigid board-like abdomen that can develop as well. Alright, so we're going to treat for shock and provide rapid transport and early notification of the hospital. So uterine inversion. So this is where the placenta has failed to detach properly from the uterine wall when it's expelled, and it literally pulls the uterus inside out. That sounds terrible, right? This is usually the result of mismanaging the third stage of labor. This is why we do not pull on that cord. We don't allow anything to tug on that cord. No pressure on that cord, because we don't want to do this. This is also why if you do a fundal massage, you make sure to support the lower portion of the abdomen above the pelvic area so that we don't accidentally push that uterus inside out doing a fundal massage, okay? So the severity of it's graded by how much of the uterus has reversed itself. An incomplete inversion, it does not protrude externally, so you may not know if this one's there. All right, a complete inversion It does not protrude externally. Once again, it's turned inside out, but it's not poking out. You've got a prolapsed inversion where the fundus actually protrudes from the vagina. And then you've got a total inversion where the uterus and everything protrudes inside out. All right? It's going to be very painful and can rapidly cause hypovolemic shock. So what are we going to do? We're going to keep them recumbent. We're going to apply 100% oxygen, non-rebreather. We're going to have our 2 IV lines, normal saline, titrating to the vital signs. We are not going to attempt to remove the placenta if it is still attached to the uterus. Okay? We're going to monitor vital signs, treat for shock. If you have oxytocin, consider giving 10 units IM to help control any hemorrhage if your local protocols allow it. We are going to make one attempt to replace the uterus. So we're going to take pressure with our fingertips in the palm of a gloved hand and push the fundus back up and back through the vaginal canal. Right? If this does not work, then we're going to cover all protruding tissue with moist sterile dressings and transport rapidly to an appropriate OBGYN facility. Okay, next one is a pulmonary embolus, and you're like, but wait, that's a medical problem. It is, but it also can happen specifically with some pregnancy-related issues. So this is actually one of the most common causes of maternal death during childbirth or immediately postpartum. All right, and some of the more frequent causes could be an amniotic embolism, where you get a leakage of the amniotic fluid into maternal circulation, and then it can cause an embolism. They may have pregnancy-related DVTs, one of those deep vein thrombosis clots that can break loose and then go into circulation. Or you could have a water embolism, where water or air enters the vagina and then into circulation after a water birth. So we should suspect a pulmonary embolism if they are postpartum or during delivery and they experience sudden dyspnea, tachycardia, AFib, hypotension, sudden sharp chest pain or abdomen pain, or syncope. Right? All things that should kind of trigger a uh-oh anyways. All right, the signs that may be mistaken for just regular shock: increased pulse rate, tachypnea, and hypotension. Management for this is going to be the same as the management for a pulmonary embolism in a non-pregnant state. Recognition is one of the big ones. High flow oxygen and rapid transport to an appropriate facility, because this is something we can't fix in the pre-hospital setting. Done.